Hello, I'm Andrew Hutchings from the Department of Health Services Research and Policy at the London School of Hygiene and Tropical Medicine. This presentation is on the findings from a study looking at the impact of the first wave of COVID-19 in England on the outcomes of emergency admissions to hospital for common acute surgical conditions. The first wave of COVID-19 had a major impact on many health systems throughout the world. Much of the initial interest was on those who were infected with COVID, but increasingly there's been interest in the indirect impact of the pandemic and health systems' responses to it on patient outcomes. In England, emergency general surgery typically accounts for around 750,000 admissions per year. This study, the ESORT C19 study, extends the previous ESORT study into the time period covered by the COVID pandemic and looks at 5 common acute conditions: appendicitis, gallstone disease, diverticular disease, acute abdominal hernia, and intestinal obstruction. The focus of this presentation is on the impact of the first wave of COVID-19, so the period covered by mid-March to mid-May 2020. We used routine hospital episode statistics data on emergency admissions to all 124 acute NHS trusts in England that undertake emergency general surgery. We used a clinical panel to define eligibility criteria for each of the 5 conditions, and also to define which patients received emergency surgery and which patients had an alternative to emergency surgery, which could be later surgery, either planned or as part of the same admission. It could be a watch and wait strategy, or it might be treatment, for example, with antibiotics. We defined primary outcome as mortality within 90 days. We extracted case mix data from hospital episode statistics, including sociodemographic characteristics of patients, the Charlson Comorbidity Index, the SCARF Frailty Index, and the primary ICD-10 diagnosis. We defined the first wave as the period covering weeks 11 to 19 in 2020. So from about mid-March, just before the first lockdown in England, through to mid-May. First, we looked at the impact for the first 6 months of 2020 on the number of admissions and how many of those admissions received emergency surgery. The analysis of mortality focused on the period of the first wave, weeks 11 to 19 in 2020, and compared mortality in that period with the equivalent period in 2019 using case mix adjusted multi-level logistic regression. These bar charts show the impact of the first wave of COVID-19 in the first 26 weeks of 2020. As you can see, the rates of surgery and rates of admission were broadly similar in the first 10 weeks of the year, but once we hit week 11, there's a sudden decline in both the number of admissions and the number of patients who have emergency surgery for their condition. This has affected all 5 conditions, in some cases quite considerably. For example, gallstones saw over almost a 50% reduction in admissions, as did diverticular disease, whereas intestinal obstruction, the fall in admissions and surgery was the smallest of all 5 conditions. Moving on to the case mix of the patients included in the analysis, looking at the admissions in the first wave and the equivalent period from 2019, we can see that there was a reduction in the number of emergency admissions across all conditions. When we look at the case mix of the patients, we don't see any huge differences in any of the 5 conditions, and for factors such as patient comorbidity and frailty, we're looking at quite similar case mix in the first wave compared with 2019. We look at length of stay, we're looking at small reductions in length of stay for some conditions, for example appendicitis, larger reductions with gallstone disease and intestinal obstruction. Looking at readmissions, there have been some increases in patients having an emergency readmission within 90 days, for example in appendicitis and gallstone disease, but perhaps the biggest impact has been on the proportion of patients who go on to have an elective readmission within 90 days, and this has dropped quite considerably across all 5 conditions. If you'd like to spend more time looking at this table, then please press pause. I shall continue the presentation. So these are the outcomes, the 90-day mortality data for the first wave. So first looking at the crude mortality rate within 90 days, as expected, it's lowest for appendicitis and highest for intestinal obstruction. When we consider all emergency admissions in each of the 5 conditions, then the odds ratios indicate higher mortality in the first wave. In the case of appendicitis, then there is considerable uncertainty with a very wide confidence interval due to the very small numbers of patients with appendicitis who die within 90 days. But for the other 4 conditions, we're looking at increased risks of 90-day mortality. Breaking these data down by whether or not the patients have emergency surgery, we can see that there are examples of increased mortality for the patients that did and also did not have emergency surgery. In the case of appendicitis, there is again considerable uncertainty with very wide confidence intervals, and in the case of intestinal obstruction, we're looking at very similar mortality rates in the first wave compared with 2019 for those patients that did have emergency surgery, but perhaps higher mortality for those patients who didn't receive emergency surgery. Finally, we undertook a sensitivity analysis to look at 2 different factors. So these 2 sets of forest plots show each of the 5 conditions: appendicitis, diverticular disease, gallstone disease, hernia, and intestinal obstruction, for those patients that did have emergency surgery and those patients who didn't have emergency surgery. And we looked at the period of 2020 before the first wave, weeks 1 to 10, the first 2 lines here. We looked at the first wave period, the 3rd and 4th lines here, and we looked at the period immediately after the first wave, so weeks 20 to 26 of 2020, that's the 5th and 6th lines here. We also looked at the impact of excluding all patients with a known inpatient COVID diagnosis within 90 days to see the impact of removing these known COVID patients. So these are the asterisked lines, the slightly lower lines of each pair. What we found was, when we looked at the impact of removing patients with COVID, this had an attenuating impact on some of the odds ratios. For example, in gallstone disease, for patients who had emergency surgery, the increased risk of odds was attenuated after we removed known COVID patients. Likewise, for hernia, we found that the increased mortality was attenuated by removing the COVID patients. But this wasn't always the case. For example, diverticular disease, patients who had emergency surgery, the effect of removing patients with a known COVID diagnosis didn't have any attenuating effect on the increased mortality. What we also found was that although mortality in some cases was raised in the first wave period, in the post first wave period, we found that mortality was not raised in comparison with 2019, and in some cases actually appeared to be lower than in 2019, for example here with the hernia patients who didn't receive emergency surgery. Again, if you'd like to spend more time looking at this, then please press pause. So in summary, the first wave of COVID had a major impact on both the number of admissions and the rates of emergency surgery for a relatively short period in March to May 2020. What we found in comparison with 2019 was that admissions were broadly similar in their case mix. There were some reductions in length of stay, some increases in emergency readmissions, but sizable reductions in elective readmissions for those patients, and we found higher mortality within 90 days. Three possible explanations for these findings. And the first is that there may be some selection going on in terms of which patients are admitted as emergencies during the first wave and which patients are selected for surgery, and there may therefore be some unmeasured case mix differences, for example in the severity of disease, leading to the possibility of residual confounding, explaining some of these findings. Secondly, COVID infection itself may explain some of the increased deaths and the impact in the sensitivity analysis of removing the known COVID infected patients suggests this might partly explain some of the increased mortality. Finally, the disruption to services and the challenge of maintaining acute surgical provision during the first wave is also a potential explanation for why mortality rates increased during the first wave period. However, by June 2020, admissions and rates of emergency surgery had returned to their 2019 levels, and relative mortality was also equivalent to the levels, if not better than the levels seen in 2019. So in terms of implications, the initial response to the first wave of COVID had a major short-term impact, and the extent of the impact on mortality seemed to be linked to the impact it had on the number of admissions and the number of patients receiving surgery. This study highlights the importance of maintaining provision for subsequent COVID waves and also other similar events that might impact on health services. The implications of fewer elective readmissions, including later planned surgery for patients who didn't get surgery during their emergency admission, is unclear and something that future research will need to address. Thanks to the Health Foundation for funding this research. Thanks also to the patient and public involvement panellists, the clinical panellists, the advisory group members, and NHS Digital for providing the data. And thank you for listening.